That's right. It is time to talk. You are listening to the Beat London 103.6 FM. It's me, Sashel, here keeping you company for the next hour. And I just want to welcome you to another panel broadcast in conjunction with Brent Health Matters. And I want to thank you for being with us today on this panel discussion, because we are talking about end-of-life care today. And it's a very, very important topic. It's one that I think for our listeners, a lot of you might think, I'm not old enough to be talking about this, and it's not something that affects me. But I guarantee you, whether it's now, whether it's when you are older, or whether you've got an older family member that's going to need palliative life care, sooner or later you are going to come into contact with this service. So it's very, very important that we have this conversation. And for me, I've got so many people on this call, on this panel today, that I'm really, really excited to speak to. And if you want to get involved with the conversation, make sure you head over to our socials at the Beat 103.6 FM. That's on Facebook, Instagram and Twitter, and get involved in this important conversation today. So now I want to introduce you to our panel. Let's start with Sharmila. How are you, Sharmila?
I'm fine, thank you. How are you?
I'm very good, thank you. So we're going to talk to you in a minute, but you are a service user of palliative care at St. Luke's Hospice, isn't that correct?
Yes.
Excellent. Perfect. We've got Elsie as well from the North West London CCG. Elsie, are you there?
Yes, hello, Sashel, how are you?
I'm very good. Really excited you're on this call. I've got so many questions that I want to get through, actually. So thank you for joining us today. We've also got Lorraine. Lorraine, are you there?
Yeah, hi, Sashel.
Thanks
for having me here today. Yeah, I'm good. How are you?
I am very good, actually. Thank you for joining us again. You are from St. Luke's Hospice, as is Cynthia. Cynthia, are you okay?
I'm very good. Sashel. I'm from the Pembridge palliative care team.
Excellent. We're going to get into that. So,
lovely.
First of all, let's start with you, Cynthia, seeing as we are talking to you. What is palliative care? Talk to me.
What is palliative? Good question. So I'm representing the palliative care, specialist palliative care team at the Pembridge palliative care unit, which is based on the grounds of St Charles's Hospital down in Notting Hill on the south side of the borough. Palliative care, the word palliative in a nutshell basically means management of symptoms, and it's a concentration of managing symptoms. We believe in supporting people individually. We believe in the term holistic. We like to use that word, which basically means that we consider the whole person. And specialist palliative care is a provision in healthcare that all service users are entitled to. And there are groups of specialist units across the country, which with nurses and doctors and other specialist physios, OTs, social workers, who are all trained in supporting palliation, that's support of complicated symptoms. And we support patients like Shamila, their families, and other healthcare professionals in our local community. Some palliative care teams are in the hospital and some palliative care teams are in the community. And we support all of our general service, our GPs, our district nurses, who also provide and support palliative and end-of-life care. But our services are there to support when the situation becomes more complicated.
I love that. I absolutely love that. And how long have you been in this sector? What's your background?
My background is palliative care, sort of born and bred, really. This is very special to me because I'm born and raised in Brent, and I had always wanted to come back and serve the community I was born into. I've been working in palliative care for the majority of my nursing career, which is nearly 30 years, and have worked in lots of different places across this part of London and East London. And it's, as Lorraine and will testify, it's a fabulous speciality to work in, and we get to meet amazing people at a very difficult time of their life, but it's very special for us who work within this speciality.
Definitely. And thank you. I commend you for the work you're doing and giving back. It's absolutely incredible. And that leads us nicely on to Lorraine. Hey, Lorraine, you okay?
Yeah, I'm good, thank you.
Excellent. So can you tell me a little bit about your background, what you do, how long you've been in the sector?
So like Cynthia, I'm born and bred palliative care. I did my training late in life. So I've been a palliative care nurse for about 20 years now.
Oh, okay.
So, but always in palliative care. So I have worked in hospice, I've worked in hospital, community, back in hospice, back in hospital, so that I get to understand the full experience of the patient journey, because it's very different in different areas. So it's very different in hospital to how it is in your own home. So I wanted to understand the patient journey. And at the moment, I'm Cynthia's counterpart. So she manages the specialist palliative care team in the community in South Brent, and I manage the team in North Brent.
Look at that, dream team, absolute dream team. We love that.
And we've worked together before. So it's
excellent.
Lovely. Yeah, it's a very small world, palliative care. So you build very good working relationships with people.
I love that. Thank you so much for your work in the sector as well. Elsie, how are you?
I'm good, thank you.
Right, so you work for the NHS North West London CCG, is that correct?
Yes, but I'm based in Brent.
Okay, so can we talk about what you do, how long you've been in the sector, why you got into it, that kind of stuff?
Okay, that's interesting. So unlike Lorraine and Cynthia, they are the ones that do the operational bit, day-to-day management, but I work at the background, supporting them, working along with them in terms of project management and strategic work, and helping them to make sure that everything is done smoothly. So, which is good, it's been going on well. So I picked up this particular project, is among various portfolios of projects that I have, because I work with other community projects as well. I picked up this in November just recently, and so far it's been going well. I've been working with Lorraine and Cynthia and a whole lot more stakeholders. It's been fabulous. It has been challenging as well, but it's fun. For me, I joined the NHS 5-6 years ago. I've worked in hospitals, I've worked in various CCGs, and I've also supported various other projects. For example, I also supported the vaccination program. It's been fantastic, yeah. And also during the COVID as well, I was at the forefront working at the trust to support discharge. So it's been great gaining experience in different areas in NHS. So right now I am focused on end-of-life care, and it's been amazing.
Yeah, and all three of you amazing people work with people like Sharmila. Sharmila, how are you? You okay?
I'm fine, thank you.
So can you talk to me about how you've come into contact with palliative care and what it's kind of done for you?
I have been diagnosed ovarian cancer in mid of 2021, and then I got a fluid on my stomach, and then the fluid they remove, and then a Macmillan nurse contact to St. Luke's Hospice to Miss Tonia, and Tonia come to my house every week to see me. And after 15 days, after again start the fluid, acidic fluid on my stomach. And then Tonia see my stomach and everything. And then they say, you want to go to the hospital. Like, I'm scared. But she managed for me everything, and they managed for me same ward before one. They say, you go, I'm with you. Don't worry about for them. And then I go, and then the acidic fluid, they remove it. And then they continues contact with me in the every week. And my hand stuck. I can't do anything with the left hand. And then they give to me complimentary for the massage in the St. Luke's. And then they do the massage, the Miss Rice. I don't know. Now I do the rolling the chapatis. I'm so happy with that.
Really?
Yes. And
wow, that's incredible.
Slowly, I joined with the all activities St. Luke's, like a music therapy, Mr. Helen. Oh my God. when I go for the music therapy, I can sleep on that time.
I love that.
Yeah, I feel peace of mind.
Yeah, I love that. So if you don't mind me asking, Shamila, so you were diagnosed last year, and where are you at now? They removed the fluid, but where are you at now in terms of recovery? How's it going?
Yeah, they give chemotherapy 9 every week after 8 hours long operation, after again 9 chemotherapy, and now they say you are okay, but now they give to me the antibody treatment, like every 3 weeks infusion Avastin and 2 tablets.
Okay, so at the minute you've got the all clear, which is incredible news. I'm so pleased to hear that. Yeah, so pleased to hear that. But one thing you did mention, I will come back to you, Shamila, but you did mention a hospice. Cynthia, Lorraine, I don't mind which one. Could you talk to me about the difference between palliative care and a hospice?
So I work out of St Luke's Hospice, and we provide palliative care to our patients. So there is no difference.
Okay.
And Shamila comes to the hospice for all of her treatments.
Treatments, yes.
Okay. So it's like Cynthia said, it's a holistic view. So for Shamila, it was really important for her to roll the chapatis.
No.
And so the therapy helps her to do that. So we're concentrating on adding good life to the days that you have left, because none of us know how long we have left.
Yeah.
So we want to make the best of everything.
Yeah.
So the hospice and palliative care are the same. They're the same. And patients can come here. So we work out of here to patients in the community, and there are other community services. There's also an inpatient unit, and the unit that Shamila is talking about is the wellbeing unit, where they have complementary therapists, they have access to physio, they have access to sound therapy, like Shamila said.
Yeah.
We have a patient and family support team as well, who will support the families of the patients. And most hospices like us, we're charitable organisations. So we have a little bit of funding from the CCG, but we're charitable organisations. So we have lots of volunteers as well who come and help us.
It's a real joint effort, isn't it? And I just thought it was important to clarify, because not just me, but I know there are a lot of young people that don't understand palliative care, hospice, and even end-of-life care. I mean, Cynthia, could you explain the difference between palliative care and end-of-life care? Are they the same?
Absolutely. They're not, well, not yes, but no, but just before I move on to that, I think language is really important, and you're quite right, because you've mentioned the word hospice, the word palliative, the word end of life care. Now, as Lorraine said, the word hospice, the hospice is a building, and we have a hospice, but actually we don't currently have inpatient beds in our hospice, and we use other hospices in the locality to use if our patients need to be admitted, because they're doing a whole London review of what's required across London. But as Lorraine said, we provide the palliative care to patients who need it. So end of life care, what I always say when people ask me that question, I say it's very contextual. It depends on the context, and the word itself is not important. It's what people understand by it, because professionals like throwing out words. But I always say, make sure if someone says that word to you, make sure they clarify it, because if you speak to one professional, they may not give you exactly the same definition. Palliative care is much easier. End of life care is a more modern word. The term was only coined in about 2005 when we had our first end of life care strategy. Palliative care has a much longer history. So it's evolved, but in a nutshell, I see end of life care as a much larger vehicle, which has components in it, including palliative care, symptom management. It's about future planning. It's about acknowledging that actually a disease, a disease may not improve. And when that acknowledgement is made, we're wanting to think, actually, what can we do to make best of an end of life care situation? So it's about future planning. It incorporates advanced care planning, which some of the listeners might have heard about. That's about collecting people's wishes in advance. So we don't want to wait until the crisis happens. We don't want to wait until someone's lost capacity or they can't speak well, because we know that if people don't get their opportunity to say what they wish, that adds extra burden to families. So it's end of life care incorporates the planning, the advance. It incorporates thinking about wills and lasting powers of attorneys and future funeral services and what music you want. I know I do, but right down to that care at the end of life. So it's a broader spectrum, and like Elsie was saying, there's lots of work we're doing with people like Elsie and services like mine and Lorraine's and lots of other services in London to look at how we can best improve end of life care for all of our rich community in Brent, because it's all about everybody's different. We try and embrace an individual philosophy, but also we have to add in that realism of, the constraints of reality. So end of life care is a bigger picture, but it incorporates lots of really important things. But I would always say to if people are going to appointments and a professional says end of life or palliative, I'd always say be brave, ask them what they really mean by that, because actually sometimes the words are used out of context.
And that's the thing, I find it interesting as well, because even when I mention it to a few people that I know, even that this programming was coming up, a lot of people seem to assume that it's an older person or it's someone who's had quite a long, lengthy life and maybe they've got sick for whatever reason. But correct me if I'm wrong, it could be any age, right? It could be anyone, any age. It could be absolutely anything.
And often we get, it's for cancer patients. It's any, as you said right at the very beginning, at some stage, that's what we all have that's the one commonality we all have. At some stage, we are going to become unwell because of something. It may well be a diagnosis like cancer or dementia. It may be heart failure, it may be renal failure, it may be frailty in old age at some stage. And end of life care is about acknowledging that and planning and supporting that journey, as Lorraine said. And the palliation are all of those lovely holistic interventions that we support with, like Lorraine said, social work, whether it's social or psychological or clinical, because we do a lot of medicines management and wanting to reduce burden symptom. And what Lorraine said was lovely was I always think that the whole job is about adding quality of life. We can't add years, but we can add improved well-being. So we open up gaps in people's days so that they can do the things they would like to do.
Yeah, incredible. Absolutely phenomenal work that you're doing. Elsie, I mean, we're talking about, how important this is. And a lot of people maybe before today would have thought, well, why do I need to hear about this? In your opinion, why do you think this is an important conversation that we need to have with not just young people, but just with everyone? Why do you think it's so important?
Thank you. It is very important, but I will say it's quite sensitive, and I understand it is a sensitive area. I mean, for example, myself, I use myself as an example. I'm from Africa. Not a lot of us want to talk about things like this because they see it as a negative talk. But like Lauren has mentioned, it is something that we need to consider, because at some point in our life, we will be sick. And it's very important to have that discussion. We cannot add the length to your life, but we can add quality, and we only have one time to get it right, which is why we are working hard with other services, not just with hospices. We work hard with social services, social care. Unfortunately, we cannot include all of them here to talk today, but they are very, very, key to what we do. We also work with carers. We have their representative and other patients representatives. So it's very important that we start talking about these. We start, having the discussion, because I believe by talking about it, we will see ways to improve. If there is anything lacking, we will be able to address it. And before the end of this show, I would like to also address one thing in terms of what we are doing in Northwest London and in Brent.
Definitely.
To make sure that we include the views of people, because we want to make sure that every resident in Brent, which is, we acknowledge a diverse community, that we hear them and we take their views on board to ensure that we provide high quality that is focused on patient experience as well.
I like that. And we definitely will come to what's being done, how can people get in touch, that kind of stuff. But I know Sharmila mentioned that, she was introduced to palliative care when she got sick. Lorraine, just very quickly, when should somebody get in touch, or how does somebody get in touch? Is it kind of like a referral when they're sick, or can it be at any time? When do they get in touch?
So usually a referral comes through when a patient has a life-limiting illness, and there may be another health professional involved who's struggling managing some of the complex symptoms that Cynthia talked about. Referrals usually will come in from either a DP or another speciality in a hospital, or district nurses may refer in, or we would take a patient referral. So, often we'll have a relative who phones up and they're just struggling with everything at home, and they may not even be appropriate for us. We may not be the right service, but by listening to them and speaking to them, we can direct them to the right services. So referrals come in from lots of different places. I wanted to really pick up on something that you said, Sachel. You said, why is it important to talk about this now? And I think that the whole world knows why it's important to talk about this now, because we've all experienced it, whoever we are, over the last 2.5 years with COVID. And COVID brought this to the forefront, and I think people talked about, I watched loads of videos on and news reports on people who didn't know what to do for their relatives, or people who hadn't planned for the future. So people usually get referred in when they have a life-limiting illness. But we can go in sometimes to just give advice on complex symptoms when people are having curative treatment, and we can give advice and help them through that period. And then we may discharge them out. Our patients can be with us anything from 2 days to years.
Oh, wow.
Depending on, yeah. And the age group, you were right. The youngest patient I've looked after is 18.
Wow.
They come into our service, and I think the oldest one was 110.
Oh, wow.
Yeah.
Wow.
So,
incredible. Absolutely incredible. Sharmila, we were talking about the fact that palliative care is incredible. It improves the quality of life. It makes you kind of think about things that you maybe didn't think about before. Personally, what impact has this? I mean, I know you can roll your chapatis now, but what impact has this had on you in terms of being involved with the service, and how have they really benefited you and helped you internally?
Yeah, the service is very good, and lots of benefit got it. I go for every Wednesday for gardening, and I grow the plant and then move the plant. Now I start on my home, the gardening. Like I feel like I'm happy, and I'm growing and do everything in the home. when I go for the music therapy, I do home for some music, like a meditation, humming, everything. And I peace of mind, because in this time you need the moral support. And I get it to St. Luke's like a too much. I don't have any words for the St. Luke's.
Yeah.
Like that they help to me, and they give the complimentary treatment also very nice. Because due to I got to third stage of the cancer, ovarian cancer, and I don't know I have third stage. But when come to Tonya and they give the old treatment to complimentary treatment, they suggest to St. Luke's. And then I go to St. Luke's, all people's like, I feel like I come to my brothers and I meet to my brothers and sisters. I'm so happy with the St. Luke's.
Yeah.
And,
it sounds incredible. I mean, it literally sounds like, the service is not only helping with the symptoms, like, Cynthia said, you help with the symptoms and managing all of that kind of stuff. It seems to be helping mentally, seems to be helping with your kind of whole demeanor and your whole just generally your mindset. Mental health is as important as physical health. I mean, we did our last Brent Health Matters conversation was about mental health and music therapy, funnily enough, Sharmila, because you mentioned music therapy. But it's very interesting that your mindset can actually have a difference on your treatment. And I personally know someone who he went through cancer, stage 4 cancer. And his mindset, he genuinely believes that it was his mindset and the fact that he was positive and he thought he could do it. That, of course, the assistance of the NHS was incredible and amazing, but he genuinely thought that he could have been defeated if it weren't for his mental health, being so positive and being so, I can get through this. And it seems like, from what you're saying, Sharmila, the service provides not just physical help or help with your symptoms, but mentally it helps you get active. It helps you really feel, like you want to achieve, Elsie.
Is it okay to say that both St. Luke's and Pembridge and the whole NHS in Brent, Northwest London, will focus in person-centered approach to care? So just like what Sharmila has experienced, we are not just focusing on the cancer or whatever ailment that Sharmila has got. We are focusing on the individual, whatever that will help the individual to lead a quality life.
I like that. It's very personalized. That's the thing I like, because a lot of stuff, when you read these kind of, you go online and you Google how to deal with whatever it is you're going through, there tends to just be a generic response. You should do this, do this, do this. But I love the fact that what I'm getting from all of you is that it's on a case-by-case basis. It's independent. It depends on what they're going through, and it's tailored to them. It's customized. And I just think that is so incredible. I really do think that is just amazing. I must say, the work you do, I'm so grateful, because, I understand that at some point in my life, I'm going to need you. Whether it's me, whether it's a relative, whether it's a friend, whoever it is, I'm going to need you, and I'm going to be grateful. And it's conversations like this that don't make you realize that you need people like yourselves until you're in the situation. We had in my family, we had a sudden death that was completely not expected, and a cousin of mine, and we literally genuinely were just sitting there thinking, okay, so we've not thought about a funeral, we've not thought about after death arrangements, like what happens then. And you were saying earlier, Cynthia, that having these conversations and getting things ready and coming to terms with making arrangements is something that can really just help. As much as it's awful and it's difficult and it's hard, I don't even like having those conversations, but my mum, she really says to me, look, right, if anything happens, this is what I want, this is what I want. And I'm like, yeah. But in the back of my mind, it registers. It does register. Lorraine.
Yeah, I remember something that really impacted me when I was a student, and I was on a placement in A&E, and a man came in and they tried to resuscitate him. Right. And they couldn't resuscitate him, and it was just an awful time. It was like a really bad experience, and it was quite sudden, and his family were there. And I watched the doctors ask his family things as we were going through, and I looked at the stress on their face because they just didn't know. They didn't know what he wanted. And so all the burden of making those decisions was put on the family. And I remember sitting with his wife afterwards, and she said to me, I wish I would have known what he wanted. Because even now I've made decisions and I still don't know what he wanted. And I thought, that's so important. You know, I want to tell my family what I want, even if they think I'm morbid doing it. I don't care, because I want them to know, because I don't want them to go through that stress. You've just lost somebody. You shouldn't have to be stressed about making difficult decisions.
But then it's a tough one, Lorraine, because how do you have these conversations? You know, are you sitting down over dinner and you say, okay, so by the way, like, when is the time to have these conversations? A lot of people are thrown into it when it happens because they've got no choice. But when do we sit down and we have these conversations and say, look, this is what I want? I mean, is it a conversation thing, or is it worth maybe writing it down somewhere and just keeping it safe maybe? I don't know.
I think it's worth writing it down and keeping it safe. I can see, I know Cynthia wants to say something. I think it's worth writing it down and keeping it safe. But there are some moments, like during COVID, I remember turning to my husband and saying, if that happens to me, this is what I want. And even if he doesn't want to talk about it, then at least he's heard what I want. But I think writing it down is really important. Somebody has got, you know, your wishes down.
Yeah, Cynthia.
I think it's a hard one, isn't it? But you mentioned something there. You said, you know, when your mum tells you about planning the future, and my father did exactly the same thing. He had a sudden death, but he always used to say what he wanted and what he didn't want.
Yeah, you know, if the song comes on, my mum will say, "Yep, I want that one played." I'm like, Mum.
Exactly, but it's almost like a shift. It's a shift in not seeing that as a failure. We always, in palliative care, we have this sort of analogy where we think, you know, people have birth plans, don't they? When the baby's coming, everyone's celebrating. And you know, life is a gift, and it's, you know, we never know when when our end is gonna come. And it's almost, you know, focusing on the importance of birth and life. The end of someone's life is so important. It's so important. And, you know, we need to give as much weight to life coming in as going out. We celebrate when someone's died. We have a funeral, but lots of us have different types of, whether it's a wake. In the Jamaicans, we have a 9-night. We, you know, celebrate 9 nights after. And, you know, when at those celebrations, you're often talking about the deceased, and it's those opportunities that people can have to open conversations and not see that as a negative, especially when you're celebrating life. And I think we are all moving closer, and I think Lorraine's right. I think COVID helped us to move a little bit closer to feeling more comfortable about talking about the inevitable, and not seeing it as a complete and utter failure and a negative thing, but actually seeing it as, well, this is going to happen. But everyone's different. For some people, it will just be, oh, let me just sort out my funeral. That's enough. For other people, it'll be, well, let me do this. For other, so it's not prescriptive. It's what everyone's different. Some people are very organized and talk very openly, and other people, it just takes them longer to get there. Longer to feel comfortable. But the more we have these conversations, this is an amazing opportunity. The more we all get more, and even us, those of us who worked in palliative care forever, we still don't, no one likes talking about it.
Of course, no, definitely. But it is something that we do need to talk about. And I know a lot of people are tuned in now expecting the Drive Time show, but this is a conversation we need to have. And, you know, if you are listening and you do want to get involved, hit us up on the socials, you know, at the Beat 1036 FM, on Facebook, on Instagram and Twitter. Let us know what you're thinking, because without having these conversations, we can't raise awareness and we can't get people the quality of life that they maybe should be having, you know. And one thing I want to know, I mean, we spoke to Shamila, I will come back to you in a minute, but we spoke about Shamila, and now for me, Shamila is someone who went through a difficult time, and she's what they would call a success story, because she's free and she's kind of getting herself back. But I've always wanted to know, and I'm going to ask all of you, Cynthia, Lorraine and Elsie, I'll start with you, Cynthia, but what is it like being on the other end? You know, if you're with someone that isn't successful or doesn't make a recovery, is that not difficult? Because me personally, you know, I find it difficult to even be around people that I see deteriorating. You know, I just find it hard. And the fact that you have to deal with that, you know, for your job all the time, what's that like? How do you manage? Does that like have a toll on you?
It is difficult. And I think, you know, it's one of those things, and as a nurse, I think it's something that it's personal to me, that I always knew I wanted to do that. A bit like Lorraine, I had an experience in my nurse training where I thought, absolutely, I want to make sure that I can do things properly. And actually within the speciality, you are given that opportunity where you can really treat people like humans. It's very, you know, individualized, it's patient focused. But yeah, absolutely, it takes a toll. But there is an extremely, and I'm not as clinically front facing now as I was when I was a sort of on the ground CNS, but it's a very special time being involved in supporting families and patients, making things as right for them as possible in a dire situation often. And you have to give a lot of yourself, you have to open a lot of yourself up, you have to really empathize. And yes, absolutely, it takes a toll, but the rewards in terms of the humanity are massive. And I wouldn't, you know, for me, my job has sort of shaped me, shaped my life. And I wouldn't, even though we have mad days, don't we? We have really busy, crazy days. We wouldn't be without it. And I'm so glad, and I encourage young nurses, doctors to, you know, come into this field, come into this speciality, because it you know, we do get that negative connotation. How can you just, you know, how can you do your job? If I had £1 for every time someone had said that to me, I'd be a very wealthy woman today.
Well, I just gave you another £1. There you go. There you have it. But you know what, I just find it really intriguing, you know, that there are people that are as strong and as caring as you, all three of you, that just really want to help. Because like I say, for me, I find it difficult. You know, I work in television and I find it difficult, and I do radio, and I find it difficult to not take my work home with me. So I can imagine what it must be like for you, you know, having to deal with that. And I just commend you. I really do. I do commend you. Lorraine, what's it like for you? How do you kind of deal with people that are kind of, not making it? What's that like?
So much like Cynthia, I'm not so, front facing as I was.
Yeah.
The team are, but the camaraderie in the team is absolutely fantastic, and the support that they give each other is really, it's commendable. The respect the nurses have for each other. But yeah, they do get upset. Of course they get upset. We all get upset, but we all have a safe space to sort of express that. And I think that you find your own kind of coping mechanism. I've got some like little sort of ditties that I keep in my head sometimes when I can feel it's getting to me, like, you know, I can't change the ending, but look at the impact we've had on the journey.
Yeah. I mean, has there ever been someone through your career, like when you were more client facing, that you just really had a connection with and you just took it personally?
So there's been a few, but there was an 18-year-old boy that really stayed with me, and it was difficult. And there's been a few along the way. There's always somebody you build like a different kind of relationship. But I think it's just the privilege of being with somebody at such a vulnerable time, and the way that people open up their home to you. You know, this barrage of people coming in and out of their home, and it's such a difficult time, and I think it's an honor.
It is, and you're incredible. Elsie, what about you?
I'm going to share a secret that I think none of you know this about me, Lorraine. So before I joined the NHS, I worked in care. So I was working as a domiciliary care assistant. I have experienced someone die in the community, in her home, and it was hospice at home. And that touched me so much because I was really close to her. And in fact, we have the same name. We share the same name. Yeah, exactly. So, and I remember the family calling, requesting for me to be there before she passes. Yeah. And they said the reason being that we were close, I would go to her, we'll have a cup of tea and we'll have a cup of biscuits, even right until at her point of death, when she was dying, she didn't know what was happening to her.
Oh no.
I was there with her, talking to her, you know, telling her, you know, just I held her hand until she, you know, gave up. It touched me. I could remember throughout that night, I was just looking at the ceiling. Like, did it just happen? So like Lauren said, we all have a coping mechanism. I tried my best to say, yes, I've done something well for the family to request for me to be there. It was to me an honor because we were quite a lot of us that were doing that work at that time, but it was only myself that was called in. And even on her funeral, I was also invited. So it is, I felt that I've done something very good wherever she is, that she will always remember that I was there with her throughout. And it's quite rewarding, really rewarding. And I think that was what really made me to join in NHS in the first place.
I love that. Incredible. Thank you so much for sharing with that. I can see you're still a little bit emotional, it's still a little bit raw, but I love the passion. Do you know what I mean? I can see that you really, really care. And you mentioned, you know, at home, you can have palliative care at home, can't you? You know, it doesn't necessarily have to be in a hospice. It can be at home.
Exactly.
Could you, Elsie, just explain quickly how that works?
So for me, because it's not really my field, but I know that nurses like St. Luke's and Pembridge, they provide what we call hospices at home. I would invite Lorraine to please touch more on that.
So all of what Cynthia and I do with our teams is palliative care in the home. So we provide care to patients in the community in their home.
Okay.
And we will go in, like Cynthia says, and give the specialist advice, but there are lots of other services. So I'll say what's happening here, and then I'll hand over to Cynthia to see how they access their services. But we have here a PAL 24 service. So that's a palliative care helpline service, which is 24 hours a day, where families can call up if they're worried about something, and they'll speak to a palliative care nurse who can guide them and support them. A lot of those calls are to support as well as for advice and symptom management. We visit to offer the advice and set up a plan of care. So that's what we do for the specialist patients. Then all the palliative patients can access the PAL 24 service. There's also a hospice at home service where they can give blocks of care, where they'll come in, a carer will come in, much like Elsie said she did, and they'll come in and they'll help give personal care and also emotional support by being around the patient. So they're the services we offer in the community, and some of the services from wellbeing can go out into the community. That was much more difficult during COVID, but So we provide complementary therapy in the community for those patients, unlike Shamila, who aren't mobile and can't get here. So we can provide that, and the patient and family support service. So I may have missed somebody out. But
no, that's okay. No, it's good to know. I mean, similar kind of thing for you, Cynthia, in your area. Is that kind of what you're...
So the problem with palliative care services across London is there's disparity,
Right.
and that's what, you know, it's useful to clarify. So absolutely, we have a community visiting clinical nurse specialists who go out into the home, and as Lorraine said, they provide sort of advice for the more difficult, complicated cases, and they support the GPs, district nurses, and the patients in their own homes. And we also have support services like social workers and occupational therapists and physiotherapists and other therapies. As I said, we don't currently have a bedded unit, but we get our beds from elsewhere. But yeah, the majority of our work is done in the community. We also are lucky enough to have a 24-hour advice line. So they don't visit, they advise. And our community CNSs, our visiting service, and our with our medic, that we have a seven days, so every day of the year there's somebody available to visit if required. And we also have we call things different terms, so it doesn't help. So we have a day, what is called a day hospice, but during COVID we had to change the way we operate, and that's become a support hub, right, which we hope then to relaunch. So we all provide the same philosophy of holistic care,
just in slightly different ways. Yeah,
the way it's configured is slightly different. And again, we have access to hospice at home, which is the social care element of palliative care. Of
course, yeah. And do you find, Cynthia, that like, how do the services support people that are kind of diverse in terms of ethnicity and religion? How do the services support those people?
I think Elsie mentioned that, you know, we are, you know, we try and be as culturally sensitive as we can be. We have a diverse workforce within both services. And you know, in terms of language, we have access to things like language line, but you know, fundamentally it's, you know, we practice and support education, not only for internally but externally, in terms of non-judgmental behaviours, and you know, not making assumption. It's always, our philosophy is always to ask people how, you know, what are their familial behaviors, what are their health beliefs, what are their religious beliefs, because actually just because you happen to be a Muslim doesn't mean you want things done this way. So it's all about finding out what that individual person, how they practice their religion, how they support their spirituality. So it's more a way of being than a specific, as you said, template of this is how we do. So, and that's again the philosophy that we share amongst the other services we work with. And as Elsie says, we do lots of work alongside what we call our primary care colleagues, our GPs, our district nurses, to actually encourage that way of being. We palliative care people work work within that holistic framework. We work within what we call a multidisciplinary, where there's lots of different specialities who all have that same philosophy. So, you know, that whole good communication and cultural sensitivity sort of goes with it. But you know, we have a long way to go, and I think some of the work that's being done in terms of, we know that we have a hugely marginalized population who don't access proportionately our services. We know that. So, and
this is partly what I wanted to get onto next as well. I mean, I will come to you in a sec, Lorraine, but what I wanted to get onto next is, because you spoke about education and learning, Cynthia, how people practice and how people live their lives to kind of incorporate that into their care. But do you find that specific communities find it difficult to talk about this kind of stuff? Because I mean, I mentioned, and you mentioned, Cynthia, that, you know, our parents have mentioned it off the cuff or mentioned it, you know, when a song comes on. But in your experience, Cynthia, have you found it, you know, that some communities just don't really want to speak about this?
Absolutely. I mean, I've worked in a lot of different areas in London, and absolutely there are whether it's age or whether it's a particular ethnicity, absolutely there are lots of cultural entanglements for a variety of different reasons. And, you know, one of the main ones being actually, you know, in specialist palliative care. I remember when I started, certain people didn't even think it was for them. Simply, you know, it's not, you know, it's not for us. It's for a white British community. Say it's not for us. So we've moved away from that, but we still have the problem of engagement and supporting people to understand that actually this is for everybody. It's not about giving up on people. It's about supporting symptoms. We know that some people do have, everybody has, lots of people have different health beliefs, and some people's health beliefs, I think Elsie mentioned, some people's health beliefs are curative bound. But even if your health belief is that your disease is never going to be, is always going to be cured, that doesn't mean you still can't access someone to help you be supported with your burdensome symptom. And I think it's about refocusing, you know, palliative care, you know, like Shamila says, if we can support quality. It isn't all about it isn't all about dying at the bedside. It's much more than that. And that's, I think that's how we engage people and take away some of that myth busting. You know, we need more myth busting exercises to support people to be more embracing of this speciality.
Definitely. Lorraine, did you want to say something?
So I just wanted to say I agree with Cynthia. I think we have got a long way to go with culture and diversity. But I have seen, I don't know whether Cynthia will agree, in the last year or so, I've seen a slight move forward to us looking after more patients that we had difficulty accessing before. So we've had a couple of patients who were cared for by a homelessness charity, and they've started to refer those patients to us. So that's good. And I think if we can keep showcasing that to other support workers out there, then they know that we're out there. I think that learning disability, we seem to have been receiving more and more referrals. And with mental health, I'm so pleased to say we've had a lot of engagement with mental health. Finally, it's like we can talk to each other because it's so important. So I think we have got a long way to go, but I think we are moving. It's slow,
moving forwards,
but
slowly but surely
in the right direction.
Perfect. I mean, do you do like talks and things to specific community groups? Like, you know, if someone wanted to get one of you to come and talk to a specific group, is that something that you also offer?
Yeah, we do. We offer it. So we have an education department here as well. And in COVID, we did a lot of education to care homes because they really needed it in COVID. But then that education went out. And I remember doing education to St Mungo's, which are charitable organisation for the homeless, and maybe that's how some of the referrals have started to come in. So we want to engage with everybody out there, and I can see Cynthia's nodding as well. So we definitely do.
Yes, it's incredible. I mean, there's so much. I can't believe that it's nearly flown by. It's almost gone already because there's so much that I just want to talk about. But just to kind of wrap up then, I'm going to go to you, Shamila. I've not spoke to you in a little while. You kind of used the service. You say it's amazing. What would be your takeaway? What would be your one piece of advice that you would give to our listeners when it comes to this topic?
Let me mention one thing. After joining the activities at St. Luke's, I am more confidential and with the positivity. And I also plan to give few hours voluntary service to Hospice in future.
Okay, that sounds good.
Finally, I'm very thankful to St. Luke's Hospice.
Yeah, that sounds incredible. No, definitely. They've done some amazing work. I mean, Elsie, is there anything that you would take away? I mean, what would you like to highlight before we wrap up?
Okay. Thank you. Hi. Thanks, Shamila, for joining us. And also thank you to everyone, Lorraine. So before we go, in case we have our audience who are listening here, what I will encourage everyone to do is to try to talk about this, start talking about it. I know it's quite a sensitive area, but it is also an inconvenient truth, because one way or the other, we might fall sick and we might need this service. And it also makes it easier for our loved ones as well. It takes the burden off them. Okay. Shortly before we leave, I would like to just mention that there is an ongoing Northwest London-wide review. So it also includes Brentborough as well. This review is focused on the community-based specialist palliative care for adults. And as we have heard Lorraine, Cynthia, Shamila share her experience and also explain the services and what the services currently provides. We want our audience and our local residents to get involved in this review and share what good care should look like and what other things we need to consider moving forward. So you can also share your experience as well if you want to. We have surveys that are there on our website, which I will mention at the end. And also you can access this from the BEATS website. We want to work hand in glove with those who have experience of the care received in Brent, mainly because we are committed towards improving the quality, fairness, and experience of service users, residents. We want to support the families and carers as well and ensure that our services are sustainable. Information on how to participate or send through your feedback will be available, as I mentioned. Another thing I would like to highlight is that we have an upcoming local Brentborough engagement event coming up in June the 15th, that is 1/5, and it will start from 12 noon to 1:30 p.m. It is going to be an online webinar event chaired by our clinical leads for end-of-life care, Dr. Lindsay Williams, alongside our partners for Central London Community Hospital, Healthcare NHS Trust. And also, like I said, it is an online event. It means that you can dial in from the comfort of your home or hospices or anywhere you are. You can even dial in using your mobile phone. So this webinar is linked into this Northwest London review. So feel free to join using the information that we have. You can visit our website, which is nwlondonics.nhs.uk.
Perfect. We're going to put all of the links and stuff on the website, all the details, all the helplines. We're going to put all the information up on our website so people can go there, get some resources, get some direction, get some help. Just before I let you go, I want to say thank you so much, all of you, for speaking today. It's been so insightful, and I know our listeners have been really engaged. As much as some people haven't really wanted to speak about it, they are thinking about it because, of course, it's something that it's a little bit taboo still, and people are still kind of getting their heads around the topic. So, we are raising awareness, and that is the point of this program. But, I'll go through all of you. I mean, we'll start with you, Cynthia. Where can people find you? If they want more information, where can people go? We'll put it on the website, but just give us a very quick summary of where people can find you.
So I'm based at the Pembridge Specialist Palliative Care Unit, and our website can be accessed through the Central London Community Health Trust website. All of our information is on there, and that's the best way of contacting us, because our contact numbers and our emails will be on there. Perfect.
Lorraine?
The best way to contact us is to go on the St Luke's website, and actually if they work their way around the St Luke's website, they'll be able to see all the services we have there. And we also have some family advice videos as well to help people if they're struggling at home. So yeah, all the services are mentioned there. That's the best way to get in touch with us.
Of course, and we will put it on the website. So if you do want to go to any of our resources, if you do need any help, any guidance, if you want to get in touch with these incredible women, please do head over to the website. We'll put all the information up. I just want to say thank you again. It's been such an important conversation, and I've learned so much already. Even just the difference between palliative care, a hospice, end of life care. I mean, something as simple as that on a base level is just so invaluable. And we do encourage all of our listeners, if you do want to have these conversations, find a way to do it that's not going to make you feel uncomfortable, and maybe write it down just so it's somewhere. But again, I will say it one more time, thank you so much for your time today. Shamila as well, thank you so much for sharing your experience with us. Really do appreciate your time and you talking to us. You have been listening to the Brent Health Matters in conjunction with the Beat London 103.6 FM. Very special broadcast today. We were talking about end-of-life palliative care. And do get in touch. Hit us up on the socials if you want to have a conversation, or head over to the website. I've got Miss Bex coming up next with the Afro Beats show. She's going to be keeping you company until 9 p.m. You definitely do not want to miss that. And then we got Mr. Silk in the building with the Afro House show. I mean, come on, your Wednesdays are sorted. We look after you here on the Beat London 103.6 FM.